Okay, as we are still filing into this virtual auditorium, I'd like to welcome you all to our grand debate on the role of coronary MRA in comparison to CTA. This is not the first time we have held this debate, but it is a testament to the importance of the topic that the name contains a little Greek language clue in that it is a coronary debate. It's a debate about one of the topics that is extremely important to us, and one where the time-space continuum of MRI is exposed to the bone. It's the one that is very, very difficult to solve. And equally, it is a topic that is of huge clinical interest. Even though this is not going to be our last debate on this topic, it's very likely that we will revisit it. I think that this moment will be regarded as a turning point in any post-match analysis, because we had some fantastic developments in the field of MRA that basically make this fight a little bit fairer than in previous years. I will just let you know the format of this debate. Our speakers, proponent of the MRA and proponent of CTA, will start by delivering their opening addresses, 10 minutes each. This will be followed by a brief rebuttal, 2 minutes each. And finally, they will have their closing statements. In lieu of your applause, to show your appreciation, I would urge you to use our chat feature and post your questions, because we will have some time to engage you in this debate. Our two debaters, obviously, they will debate each other, but the purpose of this session is to engage all of you with your comments at the end of this session. And we would also encourage you to carry on with this discussion after this session and following our meeting. With that, I'm going to introduce our MRA proponent, René Botna from King's College London. Over to you, René.
Yeah, thank you, Sasha. I don't know, I think, yeah, exactly. I think we pre-recorded the first 10 minutes, and then I think the rebuttal and the closing statement will be live.
Okay, so we're going to play it.
A very warm welcome to everyone. I'd like to thank the organizers for inviting me to participate in the CMRA versus CTA debate. Many of you probably ask yourselves the question why we should bother about coronary MR angiography. My simple answer is because we love it. But I hope I can provide you with more evidence why CMRA by itself or embedded in a CMR exam could allow to identify patients with stable coronary artery disease. Let's quickly review the ESC guidelines for the diagnosis of stable coronary artery disease. If the pretest likelihood is low, the guidelines recommend to perform coronary CTA or ischemia testing depending on the local expertise. Also, in the light of the recent ischemia trial, CTA may become the preferred test. Now the question is, why couldn't we do the same with coronary MR angiography? The obvious strength of CMRA is that it is non-invasive, does not expose patients to radiation or the risk of contrast agents, and there are no known side effects of non-contrast MRI. An even more important advantage of CMRA is that it can be performed as part of a comprehensive CMR exam, which is known to be the gold standard for the assessment of LV function, viability, myocardial perfusion and tissue characterization, allowing to diagnose patients across the entire disease spectrum of coronary artery disease. The reasons why CMRA has not taken off is because of its sensitivity to cardiac and respiratory motion, the long scan times, the lower spatial resolution compared to CTA, and the need for highly skilled MR technicians and clinicians. In contrast, CT coronary angiography is the current gold standard for non-invasive testing in patients with suspected stable coronary artery disease because it is very fast and easy to perform. It provides very high spatial resolution and has very high negative predictive value, which makes it an excellent test to ruling out significant coronary artery disease. Despite all of these advantages, CTA exposes the patients to radiation, requires potentially nephrotoxic contrast agents, and can be non-diagnostic in patients with calcified plaque. Another major limitation is that it is less well established for the assessment of LV function, viability, perfusion, and does not provide tissue characterization. The recent Scott Hart trial impressively demonstrated that CTA-guided diagnosis and revascularization outperforms optical medical treatment. The question, however, is why could we not use CMRA to achieve the same benefits? CTA is also an excellent technology to detect high-risk plaque. However, when looking at the number of events in the patients with and without high-risk plaque, we can see that there is no difference, questioning the effectiveness of high-risk plaque detection with CT. Now I'd like to review two studies that compared CMRA with CTA and X-ray angiography, and I'd like to especially focus on the diagnostic performance, prediction of revascularization, and event-free survival. The first study, published in Czech Imaging in 2011, was a two-center study comparing non-contrast CMRA at 3 Tesla with 64 slice CT and X-ray angiography in 120 consecutive patients with suspected coronary artery disease. The first interesting finding of the study is that the number of diagnostic segments was very high both for CMRA with 95% and CTA with 97%. The major difference was that the CMRA exam took in average 25 minutes, while the CTA exam took about 6 minutes, including localizers. Both CMRA and CTA were performed with beta blockers and nitrates. Looking at the images, both modalities provided very good image quality. The number of false positive and negative tests was very similar for both tests, demonstrating no major difference. Now, looking at the negative predictive value, which is the most important parameter for ruling out coronary artery disease, there was no significant difference between CMRA and CTA. Now let's have a look at the prediction of revascularization and event-free survival. Again, very surprisingly, there was no significant difference between both tests, suggesting that CMRA could be used in patients with stable CAD to rule out disease, inform on revascularization, and if there are CMR negative scans, the event-free survival rate is comparable with CTA. I also like to briefly review a more recent study comparing contrast-enhanced CMRA with dual-source CTA and X-ray coronary angiography. They scanned 57 patients with suspected coronary artery disease, and the success rate was 98% for CTA and 91% for CMRA, a bit lower than in the previous study. A very important finding of this study, however, was that the number of diagnostic segments was almost the same for CMRA and CTA for the left main and proximal coronary artery segments, which are the only ones that really matter, as we learned from the ischemia trial. Looking at the negative predictive value, we again see that CMRA and CTA are comparable, and the same is true for the sensitivity, where there was no significant difference between CMRA and CTA, suggesting that both provide comparable diagnostic information. So now the question remains why we do not use CMRA to diagnose the presence of obstructive coronary artery disease. A very important reason is that CMRA requires expert personnel for scan planning, and the exam is perceived as difficult, while many centers do not perform it. CMRA is of course also very sensitive to respiratory motion and thus requires advanced motion correction approaches. Another important reason are the longer scan times and the lower spatial resolution compared to CTA, which is why many centers prefer CTA. Now, there has been a lot of advances in the past 10 years, and many of the challenges have been addressed. For instance, we nowadays can use motion-corrected reconstruction using self-gating or image navigators, allowing for 100% scan efficiency and thus shorter scan times. Alternatively, the introduction of motion result reconstruction now allows to select the best respiratory and even cardiac phase to obtain the optimal coronary MR angiogram. And lastly, there are two abstracts at this year's SMRA that demonstrate the great potential of super resolution reconstruction to dramatically shorten the scan time while maintaining or even further improving spatial resolution despite the scan being performed in less than a minute or even in a breath hold. Here I'd like to show some results from a novel motion-corrected reconstruction approach from our lab, and I hope you can appreciate that the CTA and the CMRA scans have very similar image quality. Both scans are reconstructed to the same spatial resolution. Using this approach and again using beta blocker and nitrates, image quality was diagnostic in 97% of the proximal and mid-coronary artery segments in a predictable scan time of 10 minutes, and the negative predictive value was between 97 and 100%, suggesting that CMRA can reliably rule out coronary artery disease. As I mentioned, there are two abstracts at this SMRA meeting that demonstrate the potential of super resolution imaging with a scan time between 15 seconds and 1 minute, making this a very attractive technology that we should further explore in the future. And lastly, as mentioned at the beginning of my presentation, CMR offers more than CMRA. The landmark paper by Eike Nagel demonstrates that MR perfusion imaging is non-inferior to FFR and safely can be used to identify patients that require revascularization. In addition, MR high-risk plaque imaging has been shown to be very powerful to predict future coronary events and potentially to better guide treatment in these high-risk patients. In conclusion, head-to-head CTA versus CMRA studies in patients receiving beta blockers and nitrates demonstrate that CMRA provides similar diagnostic and prognostic information, however, while still being a bit slower. Latest developments have made MR faster, more robust, and even offer improved spatial resolution. The real strength of CMRA is that it should be embedded in a CMR exam, providing function, viability, and perfusion in a single exam. I truly believe that the future of CMRA is bright. Thank you very much for your attention and looking forward to the debate.
Thank you very much, René. Thank you for agreeing to take part in this debate and for being so brave, unlike your proposed CTA opponents who were very, very hard to identify. And very graciously, our own Giles Roditi of Glasgow University and Great Glasgow and Clyde NHS Trust has decided to play this role for us. So if we could please play Giles's opening statement, Richard. Thank you.
Hello. So, the Great Coronary Artery Debate, Pro-Coronary CTA. My disclosure is I'm currently president of the SMRA. So how did I get into this pickle? I first went to the MR Angio workshop in 2000. That was the 12th workshop in Lyon. And it was organised by this man, and I think I blame him. Philippe Duec organised that conference, but at the same time he also organised the first international workshop on coronary angiography using MR and CT angio. This is the first wildlife photograph. It's not really wildlife because the deer was stuffed and the exposure was 20 minutes. This is a deer I took last year with my camera, a bit quicker. In fact, this is a deer in moorland at 1/1000th of a second. Things have certainly advanced over the years since John McIntyre set up the first X-ray department in the world in Glasgow Royal Infirmary and took this radiograph of a child who'd swallowed a penny, the first X-ray in a hospital to have therapeutic impact. The heart is not very well resolved because the exposure we think was about 12 minutes. The exposures nowadays for patients who swallow coins are much, much shorter and the heart is crisper. This is a pound coin because of inflation. So we've gone from long exposures to very short exposures and can now get a whole 3D coronary angiogram from a CT scanner in a single heartbeat. And coronary arteries are difficult because of the complex pulsatile motion which is asynchronously superimposed on respiratory motion. This is a 64-slice CT scan from 10 years ago, showing a coronary artery stent in situ. We can see inside the lumen, and we can see plaque disease, non-calcified plaque disease. But this is 10 years old, and we no longer use this CT scanner for coronary artery imaging. And it's 10 years since NICE published its first appraisal of CT coronary angiography, which showed a negative predictive value of 99%. 10 years. 10 years from Lyon. So risk. We always want to minimize risk because we want to maximize benefit from any of our tests. So how do we minimize risk for coronary CTA? Radiation dose. We don't doubt that radiation exposure should be minimized, but what's the size of the problem? Well, this study is very relevant because it particularly looked at patients undergoing coronary CTA, looking at DNA damage and apoptosis. They showed that damage increased with increasing dose, but there was no damage detected at doses less than 7.5 millisieverts. And this CT coronary angiogram dose survey in 2014 we conducted showed that the majority of UK scanners, even in 2014, had doses less than 7.5 millisieverts. And many of those scanners that were above that red line, in fact all the scanners above that red line, are no longer in action. I know this because one of my scanners was one of the highest dose scanners at that point. We now produce CT scans of the coronary arteries at much, much lower doses. And they're much prettier. And this is in 2015. This is a scan 5 years old. This is not state of the art, but it's low dose and it's excellent quality. And these scans show not only normal coronary arteries, but they show disease, such as this patient with a double CTO, which on the basis of this scan went on for successful double CTO crossing and angioplasty. And radiation doses continue to fall as a result of wide area detectors, advances in dual tube technology, ultra efficient detector technology with high sampling rates and short afterglow, which in themselves have resulted in something like 44% dose reduction. And now model-based iterative reconstruction and deep learning-based reconstruction algorithms, such that we can work with data produced with very low radiation doses that in the past would have been much too noisy, but now results in acceptable clinical images. The result is we can scan even very young patients with extremely low doses, for example for anomalous coronary arteries. Contrast dosing, I'm not going to spend much time on this, but the very low doses we use nowadays for coronary CTA are not really nephrotoxic. Spatial resolution, well, the more spatial resolution the better. For a 3 millimeter vessel, we need 6 pixels across the lumen, which means 0.5 millimeter resolution. And standard detector widths in CT are 0.5 to 0.625 millimeter, which gives a resolution of 0.3 millimeter isotropic. With ultra-high resolution detectors on the most recent systems, we can now get down to 150 micron resolution equivalent to standard DSA systems. And these are giving really exquisite images, particularly for looking inside coronary artery stents. And unfortunately, I think cardiologists are going to continue to implant these coronary RF shields into patients, so we need to be able to see inside them. How about temporal resolution? Standard temporal resolution is about 200 milliseconds for current CT systems, but the fastest dual source systems now have temporal resolution down to 60 milliseconds. Performance of CT is quite quick. Once we've done our scout image, we plan our imaging volume, we plan a suitable site for contrast detection, and we start infusing contrast and wait for it to arrive. Once the contrast arrives, it will be detected and the scan will be taken. Well, there you go. That was it. That was the scan done. And a few seconds later, up pop all these images. This is a patient with codominant normal coronary arteries. and we'll maybe come back to them. Coronary function with CT? Well, the one that's currently garnering all the attention is CT-FFR from HeartFlow, where we do a fractional flow reserve using computational fluid dynamics. We get these nice models to play with. I'm not quite sure how much I believe them, but they do look nice, and there is some evidence building that they do reflect reality. Talking of evidence, rapid technological advances have meant that we now have about 100% accuracy in excluding significant coronary artery disease with CT, but the evidence that the bean counters listen to is that it's cheap. It may not be as cheap as NICE thinks, because in NHS England they think it's £122 or 156 US dollars, but it's certainly cheaper than a lot of other examinations, particularly MRI and invasive catheter angiography. And of course, if you can show it's cheap, people are going to like it. Here's some more evidence that I've been involved with. This is the Scott Hart trial. This is the first publication in The Lancet, where we were circumspect in our conclusions in the early days, and we said that it might reduce the risk of future myocardial infarction. However, when we unlocked the data for further follow-up, we showed that in fact we were getting a divergence of our Kaplan-Meier curves in the group assigned to coronary CT angiography compared to standard care. This is the first prospective randomized controlled trial of a diagnostic radiology test that I know of that actually shows a reduction in mortality in the group who have been exposed to the imaging test. We subsequently published our 5-year outcome data in the New England Journal of Medicine, and we not only showed a continuing divergence of the Kaplan-Meier curves, but we also showed that this was without the expense of excess downstream costs. More recent analysis of the data has shown that coronary CTA improves coronary heart disease outcomes by enabling better targeting of preventative treatments to those with coronary artery disease. What we're saying here is that it's not the coronary artery bypass grafting or invasive PCI, angioplasty and stent in these patients that is driving the change in mortality. It's the statins which are stabilizing and regressing the vulnerable plaque. We're continuing to build on this evidence. We're now investigating asymptomatic patients to determine whether coronary CT can better target primary preventive therapies for patients at risk of coronary heart disease. Of course, evidence feeds into guidelines, and guidelines, even from 2016, now mandate coronary artery CTA as a primary diagnostic test in patients suspected of coronary heart disease. Not just the NICE guidelines, but now the European guidelines and our local Scottish guidelines have followed this. So in summary, coronary CT is low risk, it's cheap, it's rapidly performed, it's accurate, it's been proven to save lives, it's evidence-based, guideline endorsed, and it continues to advance. Thank you for your attention.
Thank you very much, Giles. This was an excellent presentation, and your bravery is to be commended. We are all trying to be very unbiased and impartial, but it's a very, very difficult thing to do when you are so closely embedded in our society. So well done. Rene, you have a chance now to offer a gentle rebuttal of some of the Giles's statements, and your 2 minutes start now.
So let me try to share my screen. Can you see it?
Yes.
Oh, you see everything. Okay. So let me just, I think, oops. I'm trying again. Okay, does it work?
Mm-hmm.
Perfect, good. Yeah, Charles, I mean, I have to say you showed, of course, fantastic results, and it's very hard to compete with CTA. I fully agree. I think the images are very beautiful, and also the clinical data clearly speak for CTA. However, what I think is it really depends on the setting in which we perform a coronary MR angiography. For instance, in the UK, we have a completely different situation. For instance, here we do, in our institution, we do 7,000 scans per year, cardiac MR scans. And of course, the clinicians always come to us and say, why can't we do a CMRA? And I think that's really, let's say, where we can basically add coronary angiography to an already established cardiac MR protocol. And I just want to, let's say, review some other cases. Now just try to go back. Sorry, this is advancing too fast. So I'd like to basically review a third study where basically a group in Japan, together with Siemens, evaluated the potential of compress sensing and bringing down the scan time to less than 4 minutes compared to, for instance, 12 to 50 minutes of a normal scan. And I think you can see that very good image quality can achieved in this very short scan time. And also the scan can be slotted in a normal cardiac MR exam, for instance, right after the rest perfusion scan and before the LGE scan. So it's very efficient. So this is, for instance, one way how we could integrate CMRA into a cardiac MR exam, and it would provide additional information. So in a way, we're not really competing with the way CT is being performed, but we can enrich a normal cardiac MR exam. And of course, there are more innovations, for instance, the work from Matthias Stuber and Debbie Ali's group that demonstrated that we also can do cardiac and respiratory resolved coronary MR angiography, and which now allows really to pick the best cardiac and respiratory phase to get the nicest coronary artery images. And I have to just move something around because I can't see everything. And then if you reconstruct it, I think you can get some quite really nice data sets. I agree they're probably not as good as CTA, but I think, as I showed in my first presentation, when you look at the clinical diagnostic performance, it's pretty good, and it seems to be as good as CT. So let me just advance. So, and probably I think what we all have to do is we have to dream big. And tonight, as you know, there is the US Open final. And for the first time, the young generation broke through, and they basically are playing now for the title. And I compared them a bit with the CMRA guys. And you see that the big three guys are not playing, at least not tonight. So I think it's possible that we can compete, even so it seems that the opponent basically is in a much better position. So I think at the end, what I want to say is the sky is not the limit, only our mind it is. So I think if we keep on dreaming, if we work hard, I think we can achieve a lot. And sometimes it's even better not to have the same resources. And I also like to thank the CTA community for us to give the inspiration to work even harder. So I think it's now up to our young scientists to basically solve the remaining problems and make CMRA reality. Thank you.
Thank you so much, René. This was excellent. Giles, it's your turn now, and you will now have 3 minutes because I'm super fair.
Okie dokie. Can you hear me okay?
Yes, we can
Okay.
hear you well.
I think that's a great challenge from René to say that we've got to continue to push the coronary MRA and integrate it into our standard cardiac MR protocols. Because that's kind of my theme with CTA. When I first got involved with contrast enhanced MRA, this was our first scan in Glasgow in 1998. CTA didn't exist, CTA even for the abdomen didn't exist. And the only way we could get any imaging in this kind of patient with no femoral pulses was to do a translumbar aortogram, sticking a great big needle through the back of the patient directly into the aorta, around about the level of the renal arteries, and hoping they didn't bleed. So MRA was a huge, huge advance for us when we took this on. And that's why I went to Lyon in 2000 to find out more about this. I didn't actually go to Philippe's workshop on CT prior to the MRA because I didn't know it even existed. So I was quite surprised when I found out about that when I was actually in Lyon and found I'd actually missed something interesting. But anyway, So by 2004, which is only 4 years after Lyon, I was doing coronary CTA with a 4-slice Siemens CT scanner. And this was so slow that we had to pre-oxygenate our patients in order to get them to do a good breath hold. And we could only really look at big things like coronary artery bypass grafts or possibly anomalous coronary arteries. And we couldn't look at the native coronary arteries. But by 2010, I had a 64-slice CT scanner actually installed in 2008. And as I showed this one earlier, we were already seeing inside stents and being able to diagnose native coronary disease and high-risk plaque. And that was in 2010. And that was really what the evidence for the initial NICE guidance of 2010 came from. And the NICE guidance of 2016 that mandated coronary CT actually was based on stuff before Scott Hart. It was based on things that were before PROMIS, etc. And we've now got these really exquisite images with this really high spatial resolution coming down the line. And I think I'll go back to this patient I alluded to a bit earlier. This is a 35-year-old woman who had been breathless. And I said she had codominant normal coronary arteries, and the coronary arteries are absolutely normal on this CT. And granted, we could have done a coronary MRA on this patient if we had the technology locally to do that, and we would have shown the same normal coronary arteries. But the thing about CT is that it's actually somewhat agnostic, and sometimes we're not diagnosing whether the patient has coronary artery disease or not. We're talking about the patient having chest pain or something like that. And in this instance, as I say, the patient was breathless. So we can look at the lungs on CT. This is the same CT scan, but we've done a larger field of view reconstruction on the same data, and we've shown the lungs. So there you go, we've got the lungs. Not very interesting at this point. But in fact, this wasn't a single scan because we had done a very low dose non-contrast pre-scan for this patient, which is here. And this is showing normal lung perfusion. I'm not sure if you see where this one is going yet. I'll show you the next one. Okay, has anybody got the diagnosis? We'll use some artificial intelligence to point out the eyeball in the right lower lobe. Have you got the diagnosis yet? Anybody? Anybody shout out? Yeah, okay, this is COVID-19. Okay, this is a patient in our COVID-19 pneumonia study who's come in their convalescent phase, and we've shown that they've got unsuspected pulmonary thromboembolism on the CT scan. So as I say, as long as you cover it in the field of view on CT, it's relatively agnostic as to what pathology you're actually looking for. And if we can see on the perfusion map that this is non-occlusive thrombus with no perfusion defect. And I can envisage a time when we're using CT to stage people with, say, abdominal aortic aneurysms, but instead of staging them as we do nowadays, we'll include the heart in our scans. And we'll include the heart because we want to know about the patient's preoperative fitness. And we want to know what's going on for when the surgeon goes in and rips out half of their abdomen, and whether they're going to withstand that kind of surgical and anesthetic insult. And we can do that by looking at the heart and looking at the coronary arteries and maybe doing an FFR CT on the same thing, and maybe getting other functional data from that cardiac CT data set, all in the one single breath hold and one contrast dose. Because really, you need to look at the whole cardiovascular system because it's all connected together. And I'll come back to these implanted radiofrequency cages that we put into the coronary arteries. I don't think we're going to stop the coronary cardiologists putting these in. And if you do go to the other bits of the exhibition, and I really do encourage you to go and look and poke about on FeedLoop and find out what's going on, because in the Luminary interview with Chuck Mistretta, and Chuck plans to retire as soon as elephants learn to fly, I understand, at about 19 minutes 40, Carson asks him, if you had to do your career over again, what you would do with it, and whether you would pick MR or X-ray angiographic imaging, and what would you do to spend the rest of your time, the rest of your career doing? And Chuck said for the few years that he has left, he felt that CTA had the potential to provide the high resolution images and all the quantitative information, and eventually a platform for intervention, because his hyper technique, his highly restrained reconstruction, he can get 2,500 CTA images reconstructed per second, which means he believes we'll be able to start actually measuring coronary contrast velocities and therefore pressures. And we'll have a low dose system with a platform for intervention with a flat panel and a 3D system. with low dose that the operator can actually stand beside the system for. So there's my rebuttal. It's all one thing and it's all connected together.
Thank you,
Thank
Giles.
you.
It was a bit cheeky for you to wheel in Chuck but we'll forgive you and move on quickly to our punchy closing statement with a plea to our lovely audience. There are so many of you. Don't be shy. Post questions straight away. We'll have a few minutes for questions from the audience. So Rennie, over to you. Unmute. Unmute, Rennie, please unmute.
You're muted.
Rennie, please unmute.
Okay, can you hear me?
This is so I'm sorry.
Okay, I hope you can hear me.
Can you hear me?
So basically, I believe the role for CTA is clear. I mean, it's well established. But as I said, I think that there is a clear role for CMRA. I think if we embed it in a normal cardiac MR exam, and in the UK now we're performing more than 100,000 cardiac MRs. So if you could just include it basically in those 100,000 exams, I think that there would be a fantastic role for CMRA to make those exams even more diagnostic. In the short term, I don't see replacing CMRA like a CTA because, of course, CTA is very fast, it's very established. But as I said, I think it's an add-on to a current cardiac MR exam and will make the test much more powerful. And I think the cardiologists will be happy because usually they always ask about the coronary arteries. Even if you show them delayed enhancement and perfusion, they always want to know, so how do the coronary arteries look like? And you don't want to send them for a CT because that's not really nice for the patient that they have to go for another test. So for that reason, I think the role of CMRA is in a normal cardiac MR exam. And I think if we keep working, we can make this happen.
Thank you, Rennie. Giles, your
turn. No, I think Renee's right that it is laudable to try and have everything in one test if you can. So if you're having a cardiac MR exam, there's no reason if we can integrate a coronary MR into that, then that's good. It's just, as I say, CT is just so powerful and it's agnostic to what we're looking for. You know, we see stuff in the lungs, we see stuff in the pulmonary arteries, and we can integrate it into examinations of the rest of the body. And when we have it as a platform for intervention as well, in Chuck's interview, you know, Chuck is the inventor of digital subtraction angiography. And originally, as he envisaged it, this was a non-invasive investigation where we just injected into the veins. But they didn't really get very good images, and people started sticking catheters into the arteries and using DSA in the arteries, and found they had a platform for intervention. And that's how it took off. You know, that's what gained its traction.
Thanks,
this is Matthias. Can I ask a question?
Of course you can, yes.
Thank you both. You know, if you believe the FFR literature, then you see that it's the functional significance of the stenosis that matters. Now, it seems that with CT, you know, you can send a coronary artery tree acquired with CT to some company, they do some voodoo and they give you back some numbers. Seems to me, if you look at the physics of it, this is highly doubtful that you really can tease out all this information which they do. Now, if we are looking at MR, we can simultaneously, in principle, provide information about coronary flow, which gets the voodoo probably a heck of a lot closer to something that makes sense from a physics standpoint. I would like to hear your perspective from the two of you on this, the combined information that can be obtained with MR, which cannot be obtained with CT.
That's a question by David Marlevy as well.
So shall I go first? No, I think it would be, of course, extremely useful to have the flow information. And also, as we push the spatial resolution, we also could use, let's say, fluid dynamics to calculate FFR. I don't think this is impossible for MR. However, looking at the ischemia trial, I think what really matters, because they demonstrated if you use perfusion imaging to basically to guide revascularization, there was no difference in optical, let's say, in standard medical therapy and intervention. So basically, there was even no need to put a stent. So I think all we need to know is there a left main stenosis or a proximal stenosis? I think that all really matters to the patient.
I would say we need to know whether they have coronary artery disease or not. That's what Scott tells us. Scott tells us it doesn't really matter about the stenosis and the intervention on stenotic disease, but it's starting statins and getting the right patients on the right treatment at the right time, which is why we're doing Scott too. So yeah, we need to know whether patients have coronary artery disease. So the coronary MR that we do in the future can't just be a luminogram. It has to be able to look for high-risk plaque, I believe. And as for FFR, I agree with Matthias. I think there's quite a bit of voodoo. I think there's stuff behind the scenes that they don't tell us about. I don't use it clinically. I have it on a research basis, but colleagues that do use it clinically say that they send stuff to HeartFlow that is absolutely no motion corruption. You know, it's a really fast scan with a well beta block patient, and HeartFlow reject it saying there's motion. And they say, well, it's not motion that HeartFlow are rejecting it on because it's the calcium. They believe that it's the calcium that they're looking at and they're saying that they don't like. So I think there is some question over FFRCT, and that will come out at some point. And I agree with René that FFRCT, if it's just a luminogram data set and looking at the subtended myocardial mass, we should be able to do that on MR data sets as well.
Can I make a comment?
Tim wants to make a comment. Go ahead, Tim.
Yeah, so with regard to René's comment about the ischemia trial, I think you cannot conclude what you just said, that there's an equivalent. I mean, in that study, there was no difference in events if you revascularized based on ischemia as measured with SPECT. This was almost all done with SPECT, which we all know is a vastly inferior test compared to MR perfusion or CT perfusion or PET perfusion. So I think you cannot conclude that, but if you look at the MR Inform study, which was recently published in the New England Journal of Medicine, the study by Eike Nagel's group, I think there is evidence that you can use the physiology, i.e. the perfusion, to guide your treatment, because in the patients who underwent perfusion MR, there was a lower rate of interventions and less people went to the cath lab. I believe this was about 20 to 30%. And the outcomes were identical compared to the patients who underwent invasive angiography. So this is strong evidence that if there's no ischemia, don't touch the coronaries. At least no ischemia on perfusion MR. So I think that's a very strong argument still in favor of measuring physiology and not anatomy.
Thank you very much, Tim. We only have a few minutes left. Lots of very interesting questions coming up. I would urge all of you to carry on these discussions during our interaction time. But for now, I'm going to post a question that arrived first from Suzanne Schnell. To address to Giles. Seems like the argument for CTA is money and resolution. What do you think about the additional value MRI gives to get a comprehensive cardiac exam for assessing structure and function?
I think it's
money and resolution.
I think it's a very attractive argument to do a comprehensive examination. Of course, CT can also do a comprehensive examination. We can do ejection fractions and cardiac outputs with CT. And as Chuck says, in the future, we'll be able to measure contrast velocities in the coronary arteries and directly infer pressures from that, which will actually be better than this FFRCT CFD analysis, I think. So I think there's a long way to go for CT yet. It's as yet not mature. I think both of them are going to be giving all sorts of information that we don't really understand how it will impact patient management. But at the moment, we know that CT is easily done, it's quick, it is definitely quite cheap, the spatial resolution is good. There's a lot of people getting on board with reading these exams nowadays, although we've not got enough of them in the UK in terms of radiologists and cardiologists. We've got an even lower number of people who are expert in cardiac MR. So, you know, even if we get the technology, the workforce behind it has to be there as well.
But I have a question for you, Giles, also from Tim. Can microvascular disease be diagnosed on CTA?
You'll know, Sasha, that we're currently doing a study in Glasgow on microvascular disease with CT and then invasive measures after that. I think there might be some mileage in CT for microvascular disease if we look at coronary artery volumes in its ratio to the subtended myocardium, because I suspect some of these microvascular patients, they actually have quite small coronary arteries for their hearts. I think that there's maybe some mileage in that.
Thanks very much. I think we need to start wrapping up. We are already 10 minutes late. It's a testament to how burning these questions are still and are likely to persist in the future. I will again remind you that the topic includes the word coronary, that is embracing all of us all around the world. But we need to organize next year's debate in a less adversarial way, I think. Not that this one was very adversarial, but it's really important for us to start focusing on complementary roles of both techniques rather than organizing winner takes all competition. Because it looks very, very likely that we will be able to chisel out a unique role for CTA and a unique role for MRA in this domain. So thank you very much for your beautiful presentations, very informative, and thank you to all our participants. I look forward to seeing you in the interaction space where you will no doubt have the opportunity to carry on with these discussions.